We've done a lot of work with circulating tumor DNA. So this is the DNA that's kind of shed from a tumor. And one of the challenges is that this approach has been really, really helpful in diseases like bladder cancer, for instance. We find that, bladder cancer tends to shed a lot of DNA into the periphery, so we can identify recurrences quite early. In kidney cancer, it tends to be a really low shedding disease. And so that makes it really tough for us to detect these bits of DNA in the circulation. I'm optimistic that hopefully over the course of time, we'll identify elements that can potentially and identify experimental techniques that can actually help us increase the sensitivity of these tests so we can capture disease before it happens on scans. But I don't think we're quite there yet. I actually think the most promising potential biomarker is what Dr. Albajes had presented last year in Kim1. But again, to emphasize, and I'm sure we both agree on this, we need really sort of rigorous testing to find the right clinical application of that.
Yeah, Michelle, it's a great question. I think we need to maybe have two different perspectives. One is that useful for screening, and then you want something that is very sensitive. It could be urine test, blood test, or that's something that we could use to monitor our patient after surgery, like we are doing in some other tumors, to see if there is any signal in the blood that the patient is having a recurrence and have early treatment or maybe decide on adjuvant. So yeah, I think that Kim1 fits well there, but it needs to be prospectively validated. And we are all looking forward to have more data in this space. It's a bit lacking. We're a bit behind with RCC, but there are many teams working on this.